I will be going over exactly what the GRACE program is, what GRACE Team Care looks like, and the assessments we perform. Then I'll discuss the transition to telehealth, how that was done, feedback we've received thus far with telehealth, and then what I believe has contributed to our success. The Geriatric Resources for Assessment and Care of Elders, or the GRACE model, was originally developed over 10 years ago by Indiana University School of Medicine as an evidence-based project to improve the quality of care for older adults. The GRACE model of primary care is a cost-effective team care model that has been proven to improve the health of older adults by working with the patients in their homes and in their communities to manage their health problems, track their changing healthcare needs, and leverage social services. In the GRACE team care model, every patient is assigned a support team composed of a nurse practitioner and social worker who work closely with the patient, their caregiver, and the patient's primary care physician. This support team performs an in-home geriatric assessment of each patient, then develops an individualized care plan with input from a larger interdisciplinary team that includes the geriatrician, a clinical pharmacist, mental health professional, and community resource expert. We then implement the care plan in collaboration with the primary care physician, and we provide ongoing care coordination and deliver proactive transitional care. GRACE Team Care improves the health and lives of frail older adults with complex needs. Working together with a team of doctors, nurses, social workers, and pharmacists, we use the geriatric knowledge and techniques to improve patient care, not just in the clinic, but in the patient's home and community. GRACE uses a triple aim health reform by improving the individual's experience of care, improving the health of the population, and reducing cost. The GRACE Team Care goals are to optimize the health and functional status of patients, decrease inappropriate utilization of services. We want patients using the right services at the right time, and prevention of long-term placement. This is accomplished by integrating a geriatric team within the primary care environment, providing care management by the nurse practitioner and social worker team, along with in-home health and functional assessments addressing physical and psychosocial needs within the monthly follow-ups. The GRACE nurse practitioner performs a supplemental assessment with additional medical questions. There is also integration with the affiliated pharmacy, mental health, home health, and community-based services. Members in the GRACE program are also enrolled in Aloha Care's service coordination program. The goals of the GRACE program have been proven to improve the health and quality of life of our low-income seniors by working with patients in their homes and their communities to again manage their healthcare problems, track their changing healthcare needs, and leverage their social services. Studies show that GRACE can improve care quality outcomes and lower the cost of medical care. The outcome goals of GRACE program include a reduction in emergency department visits and hospitalizations, fewer hospital readmissions, the ability for members to age in place or defer out of home placement, and an overall reduction in the cost of care. Caregiver and member satisfaction is increased, improved quality indicators, and an increased utilization of social support services. The GRACE program assessments performed with patients in their home prior to the pandemic and utilization of telehealth include the assessment of geriatric conditions, along with assessment of health disparities and social determinants of health within their living environment. Patients are encouraged and assisted when needed to attend appointments with their primary care provider. Patients were evaluated and given ER precautions when necessary. They're educated of proper emergency room usage or urgent care usage, and even same-day appointments with their primary care provider. Long-term services and support utilized by a member were assessed and monitored. These services, including things like paid caregiving, Meals on Wheels, DME supplies. While it's definitely ideal to perform these assessments with the member in their home, the GRACE program continues to do so by telehealth and even telephonically. The monitoring care plan for GRACE members remained consistent through the transition to telehealth, and members were monitored at the same intervals they were previously. Monthly outreach was performed by the GRACE social worker and NP team. GRACE team interdisciplinary meetings were held at the following touch points. Initially for the first 3 months, then every 3 months after, unless a change in condition occurs. GRACE team meetings continued weekly and include the entire care team, consisting of the GRACE support team, which is the nurse practitioner and licensed clinical social worker, also serving as the health coordinator, our geriatrician, the clinical pharmacist, and our behavioral health specialist. Close collaboration between the GRACE nurse practitioner and primary care provider proves imperative to telehealth team care. So, how exactly was this intensive face-to-face assessment converted to telehealth? The GRACE support team began working even more closely together, attending each telehealth appointment together in conference. We increased and discovered more appropriate reporting tools for assessments. Assessments previously visualized were now completed verbally and with the use of appropriate reporting tools. Extensive pre-planning for assessments and follow-ups were performed by the nurse practitioner and the social worker. The GRACE support team reviewed medications and medication claims prior to the home visit, thus understanding what medications were being filled at appropriate intervals or what were not being filled. We can also review what medical appointments have been attended. The GRACE nurse practitioner was able to perform chart reviews prior to assessments to assist in members' understanding of their primary care provider's care plan, the discontinuing or changing of any medications, the referrals made to specialty providers. With the loss of being able to visualize pertinent information like medications and skin conditions, the use of Aloha Care's internal interpreters and professional interpreters were increased significantly. Of course, the transition to telehealth not only affected the nurse practitioner social worker team, it affected the entire interdisciplinary team. Each provider in their specialty role must also adapt. The geriatrician and behavioral health specialist could no longer make recommendations or assessment based on a visual assessment that was performed. It was now all done by patient or caregiver self-report or by a diagnosis and medical claim. Recommendations from the interdisciplinary team to the GRACE support team now had to follow telehealth capabilities as well. Keeping members of the program engaged proved to be one of the largest difficulties during this time. Without visualization of the provider, patient connections take more time and effort. Not being able to visualize their medications, their medical conditions, and home environment increased the time it took to assess and educate patients, thus increasing the appointment length. It was recognized that being online or on the telephone can be tedious for our geriatric patients. Missed appointments increased for our team as members would not answer the phone or weren't able to complete a telehealth appointment with their appropriate resource, such as they didn't have a smartphone that we could use for visualization or a computer within their home. Some solutions discovered included the increased time spent with patients and follow-up provided. The GRACE nurse practitioner and social worker gave each member their direct line, bypassing the customer service number at Aloha Care. Members reported feeling better having direct contact with the nurse practitioner or social worker when needed. Aloha Care initiated a text campaign to assist in keeping members engaged, as well as wellness rewards, where members received gift cards of monetary value for completing their wellness visits. Although transition to telehealth was not without challenges each day, with the loss of visualization by both provider and patient being difficult to overcome, and often members with no internet or telephone that will likely not gain a visual access to our telehealth capabilities, we continued to perform assessments. A quick example of where we became creative and just try to see people was utilizing Facebook Messenger, which a lot of people had, without giving all your patients your personal life access or your personal phone number. Assisting members to utilize Zoom was a little difficult as they had to download applications. With the language barrier, just proved to be more difficult than you initially thought. But we continued to operate and assess with creativity. With the implementation of telehealth by all, it was imperative that we increased our communication between our providers and our geriatric team. Despite the difficulties and challenges with telehealth, the GRACE program was able to increase their cohort membership and begin collaboration with multiple health centers. The GRACE support team continues to work hard to build patient relations and engage primary care providers. I believe the success of our program, even with telehealth, can be attributed to the increased and more efficient telehealth assessments with our weekly interdisciplinary team meetings. We continue to provide person-centered care and close monitoring, and we have increased primary care provider collaboration. Thank you again for your time today, and